Morning again, ladies and gentlemen. Can you hear me well? Just before I start, we have one of our clinics general manager here, and when I was listening to the previous speaker, then I turned back to her and I said, see, I'm not the only one who is talking about it. I even told them to stop checking random blood sugar, fasting blood sugar in our clinic at all. I'm just telling them, please do the serum insulin. That's the first parameter that I want to see, and of course I still want to see the HbA1c, because I'm still conventional, not only the anti-aging longevity doctor. So anyways, ladies and gentlemen, welcome back again to my session, which is in fact a continuation of the yesterday's session in which I was talking about the anti-aging and the programmatic approach and the three pillars of wellness and longevity. One of them, of course, being the immune system, which other speakers were talking about it who are much better experts than me. And then there were speakers talking about the metabolic syndrome, few of them, and fantastic, great lectures. And Dr. Margot, she was talking about the hormonal restoration and rejuvenation protocols in females, and perhaps you're going to have a workshop tomorrow. And my topic is, this is actually my most favorite topic. It's I'm making a slightly deeper dive into the topic of hormonal restoration. And I have a disclaimer here, a standard disclaimer, but the main disclaimer, ladies and gentlemen, that I want to give to you is that I'm going to be barely, I emphasize on this word, scratching the surface of this topic in my today's lecture. So please do not take it as a direct recommendation how to do it, because you will not be able to do it just based on this lecture. Objective of the lecture, of this lecture, as well as the objective of all my lectures and the entire objective of the European Wellness Biomedical Group is to prove that nature is wrong and aging is a reversible process. And before I jump into that, I want to ask you one interesting question. In your own opinion, what is more important, sleep or food? Then what's more important, sleep, food, or sex? Sleep, food, or sex? 3, 2, 1. And let's look at the objective data, which was published in the Journal of Sex Research in 2012. 10 years ago, 11 years ago, Fisher, Moore, and Pittenger, and they've analyzed a huge cohort of both males and females all across the different age categories, and they found out that both men and women think of sex on a daily basis, statistically way more than they think of food and sleep. So sex definitely is the priority. It's a priority above the rest and nutrition. So what are the benefits of that? Well, first of all, it's a great natural tool of hormonal optimization, hormonal stabilization, and just to make the hormonal profile sort of in a cyclic wave shape, even throughout the day, because it changes. Our hormonal profile is pulsatile, ideally. It's pulsatile throughout the day. It depends on the activities that we do. It depends on the circadian rhythm. It depends on the season. It depends on whether we travel or not, and so on and so forth. Sex is a great cardio. Yes, for those who still didn't know it, it's a wonderful cardiac exercise, and actually it should be even the equivalent to the fitness test. So if anyone have done a fitness test on a cardio machine, sex is about the same. It's a great antidepressant. It's a great mood modulator. And of course, it has multiple benefits for the cardiovascular system. A very natural treatment. If we're talking about the females, it's also a great treatment against urinary incontinence, increase the sexuality. And how about the prostate cancer? Well, we have two major studies. One was done in Harvard University and one so-called Australian study, and both studies show that there's a 20% in Harvard study and 36% reduction of the lifelong chances of development of prostate cancer in those men who are capable of performing at least 5 sexual acts per week or more, compared to those who do less than 5, like 1 or 2 intercourses per week. So the more sex, the less prostate cancer. And then finally, in early 2020, this study was published, and this is a huge study that took more than a quarter of a century and thousands of men and women. In particular, it was 2,577 men and 3,100 women over the age of 50 who participated in so-called English longitudinal study of aging, in which they've analyzed the changes in sexual desire, frequency of sexual activity, ability to have erection or become sexually aroused in women. And it was all assessed, and what they have found out that the reduction of sexual activity, as well as the desire, reduced libido, and increase in various sexual problems in both genders, both men and women, is associated with a higher occurrence of cancer, CHD, stroke, and broadly limited non-standing illnesses and poor status of health. And they've made a conclusion that the development of various interventions that will promote the sexual health will ultimately result in a better quality of life and reduce the burden of the disease in a later life. So what happens if that doesn't happen? What happens if the man or woman are not really, subjectively, are not happy with their performance? In that case, and it's defined as inability to achieve or maintain an erection sufficient for satisfactory sexual performance. In short, it's erectile dysfunction, or ED. We know that there were 2 major studies, one international study and one the Massachusetts study. It's a global study that analyzed the occurrence of the erectile dysfunction. Bad news for those who are permanent residents and Asians, and as well as for those who are from Northern America. The highest occurrence of erectile dysfunction is in Asia and Northern America. It's pretty high. It reaches like 75%. In fact, if you think that it's only affecting those who are in a 7 to 8 decade of their life, you are very, very wrong. In certain countries, the peak of the erectile dysfunction is in those who are in late 20s or those who are in late 30s. So erectile dysfunction is not the disease of the old man. Unfortunately, it is also the disease of the young man. And of course, there's a different stages, which we're not going to stop on that. What are the causes of the ED? We're going to leave the neurogenic causes, such as the traumas or spinal cord injuries and all, outside the scope of today's presentation, and we're only going to focus on the vasculogenic and the hormonal causes. Now, when we're talking about vasculogenic causes, it is a common mentality. You know, everyone thinks that it's a problem with the blood supply. No, wrong. It's not mostly it. Still, there is a problem with arterial inflow, but mostly it's the deficiency or the failure of the outflow. In medicine, we call it the syndrome or phenomenon of venous leak. And when it's coming to the hormonal changes, of course, there are, which are becoming less and less and less minority as a cause. I'm talking about this, the drug-induced hormonal decline, but mostly we're talking about the age-related hormonal decline in men. Since we're talking about the hormonal problem, just a gentle reminder that there is the hypothalamus pituitary adrenal gonadal axis. There's 2 wonderful gentlemen, Roger Guimard, Andrew Scully. They've received even the Nobel Prize for the discovery and for the explanation how it works. So, what's happening to our hormonal profile? We all know that the so-called testosterone, age-related testosterone decline. Indeed, until the age of 30-32 years old, men are experiencing, MEN, men in plural, are experiencing the yearly decline of the endogenous testosterone production. Let me specify, because decline of testosterone, it's not something, it's not the words that we should be operating in this room, okay? Like, what's your testosterone level? It's, my gym bros even do not operate this type of vernacular, you know. Everyone, my gym bros know the difference between the total testosterone, free testosterone, bioavailable testosterone, SHBG, and so on and so forth, you know. So definitely we should not be using this kind of vocabulary here. So it's a 1 to -1.5% total testosterone and 1.5 up to 3% of a free testosterone yearly decline. And then we have the guidelines from the various associations. Well, let's take, for instance, American Urological Association, which says that the testosterone level of a 300 nanogram per deciliter, which is about 10 or 12 nanomole per liter, it depends which side of the world you live, is normal or acceptable. I wonder, you know, sometimes if any of the fellas who sit on this board have ever experienced a testosterone, total testosterone level of 12 nanomole per liter. Should make them experience that, because I've experienced it. I know how horrible it is. Yeah? And in reality, we strongly challenge this concept, because we believe that the optimal range is about 23 to 31 nanomole per liter, or about roughly at least 600 and above, 800, 900, up to 1,000 nanogram per deciliter range. Now, apart from the individual decline of the testosterone production per year, there is so-called generational decline. And there were a few studies done. There was a study done in Norway, there were studies done in the United States, and they all clearly show that starting from mid-90s, like 1940s, 1950s, then 1960s, 80s, and up to now, to 2000s, there's a progressive decline in the testosterone production overall in the male population. Why that's happening? What are the causes for that? There's so many things. We're not going to talk about it today now. So the thing is that hormonal changes do not end with a problem in testosterone or reduction in testosterone production. Impaired glucose metabolism, insulin resistance as a frequent vascular neurological complication factor strongly associated with erectile dysfunction. 1. Hyperprolactinemia, high prolactin levels, also cause sexual disorders and reduction of the testosterone level. They have two mechanisms, you know. Thyroid disorders, both, whether it's a hyper or hypothyroidism, also cause erectile dysfunction, as well as sexual disorders in females. You correct those, at least 50% of the patients respond well. Adrenal dysfunction, overstress, the cortisol. Well, we can debate what's the mechanism. Maybe it's a pregnenolone steal or whatever. It doesn't matter. High stress, low libido, low testosterone level, bad, grave in the end. And then there's a greatly misunderstood role of estrogens. Up to I have to say that certain practitioners perform criminal acts, you know, which I as a doctor, I think that it's criminal by crushing the estrogen level just up to 10, you know, to single digit. And it's horrific what they're doing, just completely without understanding the mechanism of how the hormonal balance works. So there's a role of estrogen both as the inhibitory and the stimulatory hormone, and it sort of, I call it, orchestrates the symphony in a dose-dependent manner. How? Estrogen produces increased activity in the medial preoptic area, which is the area which is responsible for the sexual orientation and also for the beginning of the entire arousal circuitry. And the anterior hypothalamus, which is nothing else but the CPU, you know, the main receptor that governs the entire endocrine system, further stimulates the arousal and increases libido. Estrogen modulates patterns of sexual behavior. Read the studies of the Cohen that were done in early 1990s, because it's estrogen and the level of estrogen in the female who is pregnant, and the influence of that estrogen on the sexually dysmorphic nuclei in the fetus will define sexual orientation in that fetus for life, and will define patterns of sexual behavior. That important it is. Estrogen, increased estrogen. Now this is very important, yeah? Increased estrogen increases libido even in case of low testosterone. I mean, relatively higher levels of estrogen in case of the low T syndrome will increase libido. Prolonged hyperestrogenemia or administration of the substances with the proestrogenic effects will ultimately inhibit the hypothalamo-pituitary-gonadal axis. So it stimulates, but when you overstimulate, you're going to inhibit it. So where's the golden middle? It's called the T to E ratio, testosterone to estrogen ratio. That's what has to be maintained. It has to be in the range 1 to 8 or 1 to 12. Okay, 1 testosterone, just in numbers, to about 8 or to 12 times more level of the estrogen. Then you'll have the optimal status. And when you crush estrogen level beyond 5, it's associated with low libido, erectile dysfunction. That's how it works here. There, it works differently. Because unlike hypothalamus, penile tissue exposed to hyperestrogenemia, it impedes normal penile development, reducing the bulk of the entire penile tissue. And also, increased estrogen will promote further phenomenon of the venous leak. So what is that, the venous leak syndrome? It's a decreased volume and atrophy of the sinusoidal smooth muscles. It's a loss of the elastic fibers in sinusoids and venules, and degenerative atrophic changes in collagen fibers in tunica albuginea. Wow, sounds scary, right? I'm going to show you all the pictures. And that all happens because of the imbalance between the testosterone and estrogen, and also another globulin, another peptide is strongly involved in this. I'm not going to explain you how today. Those who want to know more, please come and visit the workshop tomorrow, when I'm going to talk about all this stuff in details with the doses, how much milligram of this or that to give. So sexual hormone or sex hormone binding globulin is greatly involved in this regulation. So let's look at some photographs. These are the micro photographs of the normal tunica albuginea, yeah, in the penile tissue. That's how it looks like. And that's how it looks in a patient with a venous leak syndrome phenomenon, and in a patient with erectile dysfunction. You see the fragmentation, degeneration, and atrophy of the collagen fibers. You see it's all aligned here, nice and smooth, and absolutely chaotic here. Dorsal artery of penis, the intima. You see the cytoplasmic vacuolization, nuclear protrusions. Normal on the left, erectile dysfunction on the right. Smooth muscles in the tunica media. Normal on the left, completely disorganized and thickened in the case of erectile dysfunction. Collagen alignment in the tunica adventitia, in the penile tissue. Normal on the left, chaotic, absolutely disorganized connective tissue, and thinning of collagen in venous leak and erectile dysfunction. And most importantly, the cavernous body, the volume that is filled up with blood, those spaces, normal on the left, atrophic by half on the right. So it's a vascular, small summary, intermediate summary, short summary. Vascular wall hypertrophy, loss of elasticity, vascular impairment, tissue remodeling, disorganization of the connective tissue, and then subcellular changes, cytoplasmic vacuolization, nuclear protrusion, mitochondrial changes, mitochondrial dysfunction, vacuolar degeneration, and then accumulation of the age, the advanced glycation products, one of the hallmarks of aging. Then the alteration seen in practically all microanatomical structures of the penile tissue, whether it's an artery, whether it's a nerve tissue, whether it's a connective tissue. Now here the bad news. You think all of that is happening in the 60s or 70s? No, wrong. Half of the percentage, half of the smooth muscles in a penile tissue are lost before the 40 years of age, in a fourth decade of life. And those who are 32-40 years old, loss up to 46-50%. Then subsequent 20 years, 41 to 60, another 40%. And then after 60, you only lose 35% what you have lost from the 40% and 46% before that. Then penile tissue contains 3 different types of collagen. Collagen type 3 is the one which is responsible for that tension that will keep and provide that the venous lock is failing. And then we can do Doppler as well, and we see that arterial inflow is also greatly impaired, but when? Not in those who are in 60s or 50s, in those who are 30-40 years old. Atherosclerotic changes start in the age of 32 years old. Fibrosis in a penile starts in those who are in the age of 30 as well. And then mitochondrial function is impaired, the nitric oxide synthetase and NAD activity is reduced. How to treat? We have to do 2 things in one time. We have to regenerate penile tissue and we have to provide hormonal optimization. How to do it? Hormonal optimization protocols, I'm going to talk about it for more than an hour on tomorrow's workshop. First of all, stimulation of the hypothalamo-pituitary-gonadal axis. There's a number of stimulatory hormones that I'm going to talk about, but it is impossible just to use the stimulatory hypothalamic hormones, synthetic or natural, whatever, and achieve consistent results. Just think of the horse. You're the rider, you sit on the horse, you whip the horse, it runs faster, you keep on whipping it. You're not giving it rest. You're not feeding it, you're not giving it water. You're not giving any nutrients to that. It will run fast for a short while. It's gonna stop and die very soon. Same will happen to your entire circuitry. You have to stimulate with the specific peptides that we have created the formulation, which we call the male or female fertility is for the female cases. And then, of course, we give the hormonal precursors and specific micro and macronutrients that I'm going to talk about tomorrow. We have done a clinical trial, a small study on that. We took 26 males in the age of 29 to 47 years old, men with erectile dysfunction and with a biochemically and clinically proven early andropause. All confirmed by biochemical investigations. We put them on the protocol, standard protocol, plus we added the more male fertility. The treatment duration of this protocol was from 3 to 4 months. And what we have observed that by the day 120 from the beginning of the study, we did not have a single man who did not respond to this treatment. A single man who did not respond to this treatment. We brought, this was day 0, 3 to 4 months. We bring them to practically almost normal range. And after that, what do we do after that? Were they on TRT or something like that? No. Just a normal health life, just supplementation, essential nutrients, and we observed them for 1 year. Yes, indeed. There was a slight decline, but it hasn't returned, not in a single patient, to the initial range of the testosterone production and hormonal profile. It was published. Was that all that we have done? No. In the same time, we were doing local treatment, which is the penile tissue regeneration. And we use the combination of the nanopeptides from placenta, nanopeptides, testicular extracts, cell extracts, and in some cases, not in all cases, but there were cases when we were adding about 5 to 10 million of MSCs to this concoction, 10 milliliters in total. That's the area where it's supposed to be administered. Never administer it on the top, on the downside, because there are blood vessels there. You just need 10 milliliters. That's how it's distributed. And a very short demonstration just to explain to you how easy and simple this procedure is. Of course, before that, we give the penile block. How exactly to do? Just use a smaller, yeah, I'm almost done, guys. Smaller size needle, just don't hit the central artery, central cavernous artery. Just 1 to 1.5 milliliter in a glance. Why we chosen that particular formulation? Why did we use the placental-derived paracrine factors? Well, earlier we had a publication on that where it was sort of like the analytical study, you know, the meta-analysis of the different publications about the placental therapy. But it turns out that it has a huge amount of different antifibrotic, antiapoptotic, angiogenesis factors that will promote the proliferation, and not only the proliferation of the, say, endothelial tissue regeneration or the smooth muscle proliferation, or the promotes differentiation, migration of the cells, but also it promotes it has the neuroprotective effect. It has the effect on the neural network inside the penile tissue, which is extremely important. The previous speaker was talking about the neural network in the pancreas. There's a neural network in the penile as well. Possible complications: incomplete anesthesia or inadequate penile block. It can be easily solved by the optional use of AMLA cream. There can be hematomal bleeding, nothing special about it, just compress, hold it for 5 minutes, 5-7 minutes, and that's it. Do not use epinephrine or adrenaline because you will cause tissue necrosis, and then patient will sue you, and most probably you will lose your license. And most importantly, the question number 1 is, which every patient always asks, is, when can I have sex? And the answer is that whenever you want. You want to have it now? Please go ahead. There are a few complementary therapies, such as the low-intensity shock wave and the suction technique. The low intensity is done in the medical facility, and then you teach the patient how to use pump, and they use the pump while playing with themselves in the bathroom at home. So the outcomes: return of morning erections, increased libido, increased penile hardness, more stable erections, successful vaginal penetrations, increased penile girth. You know, some of my patients say and you know, first time they will whisper, "Doc, my penis became bigger." I'm like, yeah, it's okay. That's the whole purpose of it, you know. That's what we're expecting. And then you can do the Doppler. You will see that it's a better systolic velocity, plus even better mood. They're very happy. Of course, testosterone is better, estrogen is high, you know. They're absolutely happy, and they're very happy with their performance. And please remember that the strength of the man is always evaluated by the size of the smile on the face of the woman that is sitting next to him. As a better hormonal profile overall, that translates into massive health benefits and improvement in quality of life. Some conclusions, which mostly say that just using the PDE5 inhibitors or the TRTs, just, guys, not enough, okay? It has to be a multimodal, complex approach, a program approach, not only towards the health management, but towards the management of the sexual life and satisfaction of the man and the couple, you know, man and his partner. Thank you very much for your attention, ladies and gentlemen, one more time. If you want to know more, please come tomorrow for the workshop. I'm gonna do a very, very deep dive in this topic, and I hope that it will be helpful in your practice and your patients will be happy. Thank you very much. Please ask our ground team, but it's around like 9:20, something like that.
Thank you, Dr. Dmytro. Thank you very much.